Welcome back. We often look at the really complex parts of neurosurgery, the microscopic work, but today we're diving into something that happens before all that, but is just as critical, patient positioning.
That's right. We've got some material here that really highlights how getting the patient placed just right isn't just, logistics.
Yeah.
It's strategy. It's step one of the actual surgery in many ways.
Yeah, the source material really hammers this home. So I have to ask, when we think surgery, we picture the scalpel, the microscope. Why is positioning this seemingly basic setup such a huge focus in neurosurgery?
Well, think about it. You've got this incredibly delicate organ, the brain, encased in this hard protective shell, the skull. Getting to the problem safely is the first hurdle.
Okay.
Positioning is all about creating the absolute best, safest path for the surgeon. A tiny bit off. That could mean, well, it could mean problems down the line. It's about the pathway, minimizing risk right from the start.
The text we looked at used this phrase, transforming deep, complex intracranial structures into a direct, accessible path. That sounds significant. Can you unpack that a bit? What does that look like?
Yeah. Imagine trying to get to something hidden deep inside a complex structure.
Yeah.
You have the straightest, clearest route, don't you?
Sure.
Okay, so in the brain, smart positioning uses things like gravity and the natural folds and spaces to gently sort of ease the brain tissue aside.
Okay. So less actual pulling or retracting.
Exactly. Less forceful retraction means less potential damage to healthy brain. Take, for example, lesions deep near the pineal gland, kind of towards the back and center.
Right.
For those, surgeons often use a sitting position. Gravity then gently pulls the cerebellum downwards, opening up a natural corridor, a direct line of sight for the surgeon. It's elegant, really.
Wow, using gravity. So that's the sitting position. But then the text contrasts that with lying the patient flat or supine for certain aneurysms. Why the complete change?
It's all about the target location. For aneurysms in the anterior circulation, that's more towards the front and base of the brain, where major arteries branch.
Like the circle of Willis.
Precisely. For those, especially using approaches like the caterianal, lying the patient supine on their back and then carefully turning the head is often best.
And why is that better there?
Because that rotation naturally helps open up a key space called the sylvian fissure. It's a large groove on the side of the brain.
Oh, I see.
Getting into that fissure gives fantastic access to those anterior vessels. And doing it this way means you put less tension, less pressure on the frontal lobe. Again, it's about the optimal angle for that specific target.
That makes a lot of sense. Another thing the text really stressed was protecting venous drainage. I admit, my first thought is always about arteries, getting blood to the brain. Why is drainage, getting blood out, so crucial during positioning?
Great question. It's easy to overlook. Think of it like during the exit roads are clear. If the veins draining blood away from the brain get blocked, either because they're accidentally damaged or maybe compressed by the head position,
Right.
then blood can back up, pressure builds, and that can actually cause brain swelling or even a venous infarction, which is essentially a stroke caused by blocked drainage. It's incredibly dangerous.
Okay, so positioning has to keep those outflow paths open.
Got it.
Are there physical limits, bony parts surgeons have to watch out for when setting the position?
Oh, absolutely. The skull isn't just a smooth bowl. There are important bony landmarks. The roof of the eye socket, the sphenoid wing, which is a ridge inside the skull, the condyles where the skull meets the spine.
These act as guides or boundaries.
Both, really.
Oh, yeah.
They tell us how far we can safely tilt or turn the head without putting pressure on critical nerves exiting the skull or even causing instability where the head joins the neck. They define the safe zone for our approach.
The source called positioning a dynamic anatomical negotiation. That sounds more complex than just setting it up once. What does dynamic mean here?
It means it's not just set it and forget it. Even once the surgery starts, we might make small adjustments. The brain can swell slightly. Tissues can shift.
Okay.
So the team is constantly assessing, is the angle still optimal? Is there any unexpected pressure? It's an ongoing process and negotiation, like the text says, between the ideal access we want and the anatomical realities we're seeing.
So it requires constant vigilance.
Exactly. The aim is always deliberate, often symmetrical positioning where possible, respecting the anatomy, always balancing that perfect view with absolute safety. It's a continuous calibration.
It really drives home how much detailed planning and anatomical knowledge goes into neurosurgery, even for what seems like a preliminary step. It's not just prep work.
Not at all. It sets the stage for everything that follows. Good positioning makes a difficult surgery smoother and safer. Poor positioning can create unnecessary challenges, or worse. It truly is foundational.
So the key takeaway is that patient positioning is this really active, thoughtful process, balancing access and safety for these super delicate operations.
That's it, precisely. It's about maximizing the surgeon's ability to help the patient while minimizing any potential harm from the approach itself. And maybe a final thought for you listening. Think about how often in complex systems, whether it's surgery or something else entirely, those initial setup decisions, those seemingly simple adjustments, can echo through and have really profound effects on the final outcome.
That's a powerful point to consider. Thanks so much for walking us through that. It sheds a whole new light on the preparation involved.